thank you so much for giving me this opportunity to be with you. And first of all, I would like to thank for the kind words of introduction. But let me tell you that there are many people who have done the procedures much earlier than me. Only thing is I am interested and I was pursuing. So it's not that I have done many procedures first time. But anyway, thank you so much for your kind words, and thank you, Krishnas. We have been associated for quite some time. When his MD time, and he was a very good PG student as well as he was a very good colleague at that time. So that I realized that he has become a gastroenterologist because he worked in that department probably because of Professor Narendra Nathan and all other luminaries in the department. So thank you so much. Today we have something called recent advances in GI endoscopy. It's a very vast topic. Let us see how much we can go in. But once you look at there are a lot of developments that has happened in endoscopy, especially in the diagnosis, something like image enhancing and etc., etc., etc. So we have an area of diagnosis where we had a lot of recent advances. And then as well as when the diagnosis is enhanced, naturally the treatment also gets enhanced. So these are all possible because of concepts by certain people, why you want to develop further. One was that people are seeing endoscopy and they are looking at the lumen. And they are only seeing the mucosa. So then people started thinking, why can't we just look beyond that? Why can't we just see the wall of the intestine? And that is how the marriage between endoscopy and ultrasound came together and endoscopic ultrasound came in. Though it was there for quite some time, maybe in beginning in 80s, but it actually became so popular only in the late 2000 in India. And then came in, now people thought that why can't we have an endoscopy without a wire? That brought in the possibility of wireless endoscopy, that is video capsule endoscopy. And that also is basically for other reason, no? Because small bowel was a hidden area that's very difficult to reach. So capsule endoscopy actually, we thought, though we earlier thought that small intestine is an area where rarely you get major diseases, but it became, and it is inapproachable only by surgeons we can do, or by intraoperative laparoscopy, etc., etc. I mean laparoscopy, LAPE or intraoperative endoscopy. Then came in now, just by seeing is not sufficient. You need to have interventions. That is how people thought about that device-assisted endoscopy, which you will come to it later. Then came in the field of image enhancing endoscopy. We are all having white light endoscopy, and even that the image has enhanced from, I am sure, all the senior colleagues sitting here, when they were doing a upper GI endoscopy or colonoscopy with the non-video or the fiber optic type. And after, when you go to video, the image enhancing was much better. Now it is even much, much better. Then there was attachment of organs like liver and pancreas to the intestine. So people started exploring that, and that is how ERCP came in. And then people want to look into this area, how that is how cholangiopancreatism came in. Then the idea of flexible endoscopic surgery. We are all having laparoscopic surgery only with the rigid one. Endoscopy earlier were rigid one. Then with the availability of flexible endoscopy, then people thought, why can't we just go inside the tummy through the mucosa and inside see the peritoneum? That is the natural office surgery that is not, but though it did not go further much, but that gave us a lot of information and experience to venture into the third space. And that is, third space surgeries came in, there are a lot. I have just named ESD, poem, stair, which are more common. Then people thought that in spite of all this, your diagnosis is not certain. You want to be more characteristic and you want to have a proper diagnosis, accuracy in diagnosis. That is how people thought your detection rate can improve if you use computer-aided detection technologies, that is artificial intelligence. So we have image enhancing endoscopy, newer endoscopes, endoscopic techniques, accessories, and training. I don't know whether I'll be able to touch upon everything, but I will try to do something justice on that. When you talk about image enhancing endoscopy, we have initially white light endoscopy, then different types, arrays of endoscopy which actually came in. And early detection of GI cancers, whereby magnifying endoscopy, as we can look at that, then came chromo endoscopy, then optical chromo, that is narrowband imaging, then came confocal and endocytoscopy. So this is just to show a chromo endoscopy, how different it can actually show the lesion is. That this is a white light endoscopy, and this is actually the chromoendoscopy. That is actually defines the lesions better. It may not give you an enhancement, but it's actually give a definition is much better than that. Then came, that chromoendoscopy is a messy procedure, and people thought, why can't we have it through the computer itself, computer-aided chromoendoscopy. So how this can be done is actually by filtering certain lights. This is a white light, you filter, and then you get NVA light, which can actually absorb vessels as well as especially the vessels. And by looking at the vascular pattern, you can try to make your diagnosis. And this is actually, when you for characterization or detection of any lesion, you have to have first identify the lesion, characterize it, confirm it, and then take for treatment. So narrowband imaging, when you look at that, it actually filters, and only 2 lights are passed here. And look at the blood vessels. We can see that the green and blue, that actually superficial and deeper vessels. And this is actually an NBA will only pick up superficial vessels, and it colors darker color. You can see that is very clearly seen here. And it also shows the mucosal pattern, but more importantly, it shows the vascular pattern, and different types of vascular pattern can be identified. And with that, we can actually make a diagnosis. Is I'm dealing with a normal mucosa, or am I dealing with a abnormal mucosa, dysplastic versus malignancy. Similarly, this is actually to show the vascular pattern here. And there is another, why the narrowband imaging, when it came down, then actually there are a lot of classifications came in. And just because looking at the vascular pattern, we can say that this is actually a hyperplastic, you are classified into, this is a Janet classification, and you can classify and find out whether which lesion needs to be taken up seriously and which can be left alone. Suppose it's a hyperplastic polyp, you can actually even leave it alone. So this is another technique of looking at that. Can we go beyond that? That is the reason people have tried to look at certain other things like texture and color enhancement imaging. This is actually the oral cavity, and they actually split the image. This is a black and white, and this is the base image. When you mix these things together, the texture can be improved, and you can see that when you actually the color as well as the texture can be combined together, you get a very clear-cut picture here. You can see the vessels and everything well. So that is an enhancement of endoscopy that has come here. This is actually a texture, color, and enhancement. This is actually coming up. So you can see that 3 images are fused together: brightness, color, texture. So when everything is fused together, the clarity of the image goes up. So this is a new technology which is coming into the endoscopy system, and it's available in certain countries. Some of the scopes have already come. So another new technology that has come is the red dichromatic imaging, the RDI. This is actually just by adding another light source or LED, there is the amber light into that. This is because you can see this is the green, this is the red. Red will look into the deeper one, but that will be absorbed by the blood vessels so that you cannot see well. But amber will show these vessels very well. So when there is a lot of bleeding, the amber light will concentrate there and it will show here. This is RDA technology. You can see this is bleeding occurs there. You can see, I'll show you again. Sorry. See, when the blood is there, you can see that the endoscopy actually concentrates on the maximum amount of blood coming to the bleeding area. So you can actually use this, and you can see the bleeding very well clearly. So you can use your therapeutic, especially important in ESD, POEM, etc. In other words, you can actually, in white light, you see the blood vessels like this, but in deep blood vessels are seen better in RDI. And when you have got white light, it's like that. So you cannot see where is the bleeding point. The whole area is blood. Here you can actually concentrate, and you can use your co-grasper or whatever it is and go. Even it can be used for an ulcer. It can be done in other endoscopic surgery as well. This is actually a new concept. You combine everything, detection, characterization, and everything together. And then it is known as EDO of scopes, where actually you utilize this, use 2 different mirrors to enhance the image. You can see that here, one area is clearly seen, this area is not, here it is clearly seen. So combine these 2, so the depth as well as the proximal one will be combined, and so you will get a wider depth of imaging, that is EDO of scopes. So coming back to our magnifying endoscopy, in magnifying endoscopy, you assume cellular changes from the mucosal pit or vascular pattern. So something like an optical histology, you actually observe the shape and change of the nucleus, or rather the cell, for optical histology. So let us look what is it. This is actually a leaf which was seen in the colonoscopy while doing a colonoscopy. This is actually the white light image. This is actually a narrowband imaging which actually shows that you can see the lines, everything, or the leaf bands, everything better than that. And this is again, this is a magnifying endoscopy, this is a narrowband imaging. So this is a little better seen there. Similarly, when you do an optical histology, you can see the cells there. Can you see the cells there? The nucleus is not seen because it's a dead leaf. So you can enhance it and you can see all the cellular pattern in the leaf. That is actually the optical histology. So here actually what we do is apply the endoscope to the target mucosa during the endoscopy examination and try to look at the living tumor cells and capture the ultra magnified pathology images. And this can actually differentiate between neoplastic and non-plastic lesions. And the first came in was confocal laser endomicroscopy. It actually illuminates the tissue with a low power laser and it detects the fluorescent light reflected from the tissue through a pinhole. And the image is reconstructed and used as increased in a spatial resolution, and that gives an image, something look like that. But you have to give an intravenous fluorescent, etc., to image that. This is actually an endoscope, and this is the probe which is actually coming out through the endoscope for this. And this, the cells will look like this. You can see the villi here. This is better seen, and there are even classifications based on the Miami classification, etc., depending on this. So one is actually the histopathology, and other is actually CLE, which I have not covered. So what is endocytoscopy? Here actually you have got an image enhancement up to 520. Confocal has got almost 1000. And here with the same endoscope, you can try to see a histopathology here. So this is actually an old generation endocytoscopy. You can see this is the esophagus, scattered benign cells normal, and this is a carcinoma where you have got crowded nuclear material suggesting possibly this is carcinoma. And it has to be stained with some coloring agent while you do the endoscopy. And this is the newer endocytoscopy. Here the probe is not necessary. You have the scope. Only thing is that a elevator, you push it and elevate to maximum, come closer to the tissue, you start seeing the, it's actually a contact endoscopy and you start seeing the images there. So you actually push the elevator maximum and you get the image there. So you can see esophagus, colon, etc., and you can classify, characterize it. So how does it occur? It's because of light gate and objective lens. It actually goes and scatter and look at the nucleus, deeper superficial, mostly on the superficial layers. And that staining when you use, and that will be picked up. And that will be imaged as the, this is just to show you this scope, endocytoscope. And you can see there, the cells are being stained, the nucleus is stained. I'll come to it. This is unique, a different type of endoscopy, that is a 290 series. And you need to stain. People use two types of stain, methylene blue and crystal violet. Methylene blue will stain the nucleus. Crystal violet can stain the nucleus and cytoplasm, but it will stain the same color. But when you use both together, that is CM staining, that is crystal violet and methylene blue, then you can contrast, you get a contrast between nucleus and cytoplasm. That is how you identify that. So this is actually a colon endocytoscopy where you can see the cells very well. This is the histology, and this is actually endoscytoscopy, which actually is the diagrammatic one. Here is again the EZ2, that is actually looking at adenomas. This is actually the histopathology, and this is just showing the crypts and the nuclear material, crypts and nuclear material. This is a crypt lumen, what you see here. Similarly, here it is already an advanced cancer, invasive cancer, a lot of scattered nuclear material. So you know that in malignancy, you have got the increased size of nucleus and nucleoli, etc. So by looking at that, you can say that it's probably I'm dealing with cancer. This is actually endocytoscopy vascular pattern, which I did recently, which you can see these vessels, you can even see the RBCs flowing that. And you can see the blood vessels around the crypts there. And this is without any staining, without any narrowband. You can see the crypts there, very well seen, blood vessels seen there. So looking at the vascular pattern, you can actually say that, so looking at the cellular after staining, even without staining, looking at the vascular pattern, you can actually classify this and tell that probably I'm dealing with a malignancy or not. This is actually normal or hyperplastic one. This is actually an adenoma. You can see the bigger vessels, but irregular shaped around the crypts. You can see these are the crypts, and this is actually the blood vessels surrounding them. This is actually club-shaped vessels, irregular vessels, thick vessels. The caliber is changed. This all suggests probably I'm dealing with a malignancy. This is one of our patients. This is actually a flat adenoma of rectum or sigmoid colon, I think. Narrowband imaging shows abnormal vascular pattern, but not to the tune of malignancy. And this is actually endocyto picture. You can see these are the crypts. Lot of nuclear material, but not in malignancy. And this is the histopathology, which also looks gives you the diagnosis an adenomatous polyp, tubular villous adenoma. Similarly, another case, you can see that this is a adenomatous pattern, but there are a lot of abnormal looking area here, and this is actually a significant dysplasia occurring in one of the area, and that is it. This is actually a case of ulcerative colitis with a polyp there, and this area shows abnormality on narrowband imaging. So this looks like more of invasive cancer, and this look probably a dysplastic one. So narrowband imaging, endocytoscopy, abnormal vascular pattern, very bad vascular pattern, and here it is suggestive malignancy. And what we have done on endocytoscopy, we have seen a lot of nuclear material suggesting probably this is. And this is actually histopathology. You can see this is the malignant area, and this is again malignant area. But combined with them, this is actually another case of ulcerative colitis. This is the histopathology, and this is actually the endocytoscopy. These are the crypts with the probably dead material inside. I'm not sure that I'm dealing with a crypt abscess there, but these are the crypts, but a lot of necrotic material inside. So you get something similar to that of even in ulcerative colitis by looking at activity you can identify. So people are trying to classify ulcerative colitis looking at the endocytoscopy, and probably this may come in the future rather than instead of taking biopsy, you can look at endocytoscopy and make a diagnosis. Is that another case of ulcerative colitis of mine? You can see all these crypts are heavily inflamed, a lot of tissue, a lot of cells there infiltration, and this is histopathology showing the same there. So just you cannot make 100% diagnosis. So people are trying to look at whether we can combine a computer-aided diagnosis on this. And this is as endobrain. And you can see that looking at the vessels and all those things, actually this gives a diagnosis. Whether it is neoplastic or non-plastic, it will tell you. And this is at another case. This is not mine. You can see this is a stained one. We are using endobrain. This is actually, I got it from Olympus. This is actually by the master, the person who invented this. And you can see these vessels. And you can say whether it's invasive cancer or not. The machine which I have, it will tell you it is neoplastic and non-neoplastic. It will be upgraded soon. So computer-aided diagnosis in endocytoscopy, it actually looks at the nuclear features, and also it can combine with NBA even prior to staining to give a diagnosis. The clinical implications are tremendous. Probably it may not come in the immediate future, but probably in the future, at least in selected centers, this becomes quite useful. Another new area which has come in is probably coming in. It's not easily available. It's only still in the experiment stage. And this is actually photoacoustic imaging endoscope. This has been actually tried in skin and other areas. You can see this is actually a skin lesion. It's a melanoma. You can see the blood vessels are seen. This is actually images which actually keep on the surface. You get an image like this. You can see the tumor just in the skin. This is actually the endoscopy probe. And there are mostly it is studied in porcine models, but in one human rectal tissue, they have tried and found out that they can identify malignant cells versus non-malignant cells, but not in a living human, but it's a receptor specific. So what we know that in spite of all this, the gold standard is histopathology, but we can actually aid and target and probably make a tentative diagnosis early itself so that you can plan your treatment early. So how can we enhance again diagnosis by endoscopy? There are actually new novel colonoscopes which actually enhances the diagnosis as well as the detection rate. It's actually to widen the field of view. It incorporates more than 1 cameras, and field of view can be expanded up to 330 degrees. This is one of that type of scopes, and you can actually see that you see 3 images there. So one is the central image, which you see naturally, and the other one from both sides. So you are unlikely to miss lesions there. You can also have add-on devices attachable to standard endoscope to increase the detection rate. You know that the most important thing which people are worried is in the Western world is adenoma detection or the missing rate of adenomas. So there are certain quality indicators also you have to look in. And this is actually the wide angle scopes available at present. Not widely available, it's actually in the pipeline to get in the market. And one is the full spectrum endoscopy platform, and another is extra wide angle, and that is coming out with Olympus, coming by Olympus, and self-propelled disposable colonoscopies. These are all things which actually enhance the cecal intubation, reduce the cecal intubation time, or reaching the up to the cecum faster or less fast, time consuming, and also the number of adenoma you are missing. And also there are certain add-on devices, very simple devices, and these are the different types. You know, endocuff is the picture here, and actually endocuff vision is here. And I will just show you on the video. There are different areas we can attach the tip of the scope to enhance this one. And this is actually a very simple one. And you can see that it actually it looks under the scope, and because of the flexible cuff attached to it, it can actually look at areas, and you can less likely to miss adenomas on that area. So you have to actually, there are certain metrics you have to look into this, and these are actually cecal intubation rate, polyp detection rate, adenoma detection rate, adenoma per colonoscopy, polyp miss rate, and adenoma miss rate. And that is how they are actually compared, and they found that the overall success rate is quite good. Coming to therapeutic aspects of advances, there are in different areas, and it's so many. So I will just briefly touch upon certain areas, and GRD is one area where actually people are either they have to be on many years on PPI, or they have to go in for surgery, and even after surgery, some group of people still require PPI. So people are trying to look at, there are so many procedures have come into the market earlier, and most of them did not survive for long. And some of them are actually promising, and probably some of them actually produce exactly like what we do in fundoplication, they try to do in endoscope fundoplication. Similarly, there are certain areas which I will come to it. And GRD is actually for diagnosis. There is through the endoscope impedance probe is being developed by your company. And probably you don't have to do a 24-hour pH. What you can do is you can just, in doubtful cases, while you do endoscopy, you can pass this transducer and or impedance probe and make a diagnosis of at different levels of the esophagus. You can actually make a diagnosis of gastroesophageal reflux. Especially this is very important in patients where they complain of reflux disease or reflux symptoms. Endoscopy is negative, and you want to make a diagnosis of reflux actually present or not, or endoscopy negative reflux disease. This may be useful. So what are the therapeutic options available? The endoscopy therapeutic option. Endoscopic anti-reflux modalities include radio frequency ablation, which all of us know, and I am sure some of you must be doing it. And in many of the workshops we have seen it, and some of the workshops we have assisted also. Then comes the fundoplication, that is transoral fundoplication, and then mucosal resection. In fundoplication, 3 systems are available. One is Ishafis, another is Muse, that is Israel one, and GERDEX. GERDEX, I'm sure most of you are aware, and is available here. And mucosal resection is anti-reflex mucosectomy, ARM, still in many centers in India, they are doing it also. This is the RFA for GRD, that is the RFA system. You have different levels. This is actually the needles which are coming out. This is a balloon, and the needle has got RFA. This is the attachment for RFA. This is known as strata, and it is given at different levels so that the reflex mechanisms the reflex procedure will actually reduce, and GE junction become more intact probably. And this is actually, studies have shown this is quite useful, at least symptomatically they improve a lot. You can see that this is the ultimate effect of this one, is slight narrowing of the GE junction, reducing the reflex disease. This is the isofix, and this is again, you do something like a fundoplication very close to that of GE junction. This is retroflexed inside the stomach, and then you apply clips so that it's actually the lumen or the opening gets narrowed up. And this is the Muse at the Israel one. It actually uses ultrasound also. It is done at the level of lower esophagus. This is the GERDEX one, which I'm sure you must be knowing about. I will show you a video on that. This is the GERDEX system. This is looks a very plumbing machine, but it is over the gateway, you pass over into the esophagus, and then into the stomach. And there is a side, once it, there is a side channel also, you actually use pediatric scope through that, or a nasal endoscope through that. And then this is flexed that. This cannot be used for a huge hiatus hernia. It can be used only for a lesser degree of hiatus hernias. And then it can be used, and you can apply the clip here, release it. Mostly one is sufficient. Sometimes you may require 2 or even more. And this is found to be quite efficient. And this is the end of it. You can see the junction becomes quite reasonably not very tight, but because the scope is there now, so that it will not become very tight, and it is found to be useful. So let us look at the results of all this. It is found that all this actually produces some amount of benefit. The long-lasting benefits are not sure, but it is said that probably these actually are good, and there can be some complications as well, especially bleeding, even pneumomediastinum perforation sometimes, etc. This is the anti-mucosal resection. You use, just like any other ESD, you go into the GE junction, assess the GE junction retroplex, and find out that there is actually, this is the area we are here to inject and elevate and then cut. Just below the Z line, you come there, inject. Then you resect it, another area. One portion, on that portion is left behind, so that will, otherwise you will get stricture issues. Even with this one, sometimes you get stricture. Ultimately, the aim is to reduce the G junction orifice, and you can see this one that is left behind, and after, when everything is healed, they get some relief on that. So after that, we'll just go through the journey of small bowel. That is a quite difficult area to look into, and now it has become very easy, probably easy, not very easy, probably easy. Capsule endoscopy have evolved passively moving diagnostic devices now to probably a moving system. We can actually actively move and potentially do therapeutic capability. That the biggest problem with the capsule endoscopy, you have no control over that. How it, where it stops, where it goes, and all. But though we can see it now externally, but you cannot control it. We cannot stop it. Suppose in the future you want to do some therapeutic potential, therapeutic work on that, you have to retain the endoscope, capsule endoscope there itself. So you need to have some mechanism. So people have tried to look at certain area, certain things, and they found that you can actually control the movement, passage, and orientation. Everything can be adjusted on this one. And also people have tried to put in probable therapeutic potential. And there are some studies going on with probable biopsy or spraying of spraying of hemospray, etc., like that. And also, as artificial intelligence is coming into capsule endoscopy as well. So this is actually a magnetically gained assisted capsule, and this I am sure you might have seen in the YouTube, and or the person who invented actually tried to do the capsule, do the magnet and try to see that whether it is moving or not. And this is actually a capsule with the biopsy potential. You can see that punch biopsy can be done through that. So these are all actually not available, but this is probably available in restrictive areas. So if you look at all these clinical studies using artificial intelligence capsule endoscopy, it is found with that it is they all use neural network systems, and it is found to be quite useful in this one. So coming to the therapeutic potential of small bowel, that we were all accustomed to the push endoscopy. Then came the device-assisted endoscopy. The device include balloon, single balloon, double balloon, or the latest one is spiral. Earlier we have a manual spiral, now we have got a power spiral. So once we have got a power spiral, probably the intention is that you reduce the time taken to reach up to the cecum or the maximum area of interest. This is just to show you a power spiral. So this I'll just do with the mechanics now. This is the spiral is attached to the scope. And it is motorized. You have got all the accessories for therapeutic work. So it is quite said to be very, probably you can do mechanical, you can do a lot of work on that. And I have even seen a video where actually an ESD was done in a small bowel in the distal jejunum. And so these are the therapeutic potential with this. This is actually not meant for ESD, but it's actually, we can look at the bleed, we can take biopsies, we can put clips, we can do polypectomy, all this can be done. So because of these spiral movements, actually these plates and the scopes actually go advance easily. So instead of the intestinal loop actually plicates over the over tubes, which happens in the balloon endoscopy, here actually this takes this actually goes over the spiral so that the scope advances here. So while it is withdrawing also, you can watch and do the procedures, and you can also go retrograde as well. So coming to third space, there are a lot of procedures. And I believe this is all because of finding out there is a potential space in the bowel wall itself. So since there was no name on that, the submucosal space, people started labeling it as third space. So the first phase is actually the lumen, and the second phase is said to be peritoneum, and third submucosa. This is one classification. Some people say it is different, but whatever it is. So coming to endoscopic mucosal resection, that was the initial thing which us came into. And EMR, we are all aware, many people are doing. I'm sure that most of us are doing. And ESD, some people are doing, but it's actually a little more difficult technique, but it's a very, very good technique. So how it happened is actually identifying this one. There is a loose area in the submucosa. So if you inject, you can actually elevate. So what happens to the mucosa? The diseased mucosa gets elevated. So you get a good cushion to cut through that. And that is actually a big revolution of identifying the space. And it is found that this area contains only loose tissue. So if you inject something, you can elevate it. And because worry is perforation, no? So you can elevate it, and the muscle, it can get separated from the muscle. This is a case of Barrett's esophagus with adenocarcinoma, an elderly person who doesn't want surgery. And we did a PET scan, we did a EUS, everything, and we found that this is localized only to the lower esophagus, and that is only in the mucosa only, and it's not going beyond the submucosa. But it's a very extensive disease. You can see this is actually the whole area is involved, and this is the less involved area. And this is the endocyto picture you can see here. And this is actually the non-cancerous area, but it's a Barrett's one. This is a cancerous area, and this is, we cannot say it's a Barrett's, but you can say that's probably a cancer. And biopsy came as adenocarcinoma. So we decided to go ahead and do the endoscopy submucosal dissection. You can see that's a bigger lesion. And Dr. Prakash has done a wonderful job on this. You can see that. It's a huge one. Now we can see what is left is very little one. So we are worried whether we are going to deal with stricture, but fortunately he did not have. But actually he has got some more area which is probably which needs resection in the future. This is a gastric one. Again, what you do is actually you require a high resolution endoscopy, 190, and mark the lesion. Then you inject, elevate it, and then you can use different types of needles. The commonest one people use is the dual knife, where you can inject as well as you can dissect, or you can use hybrid knife, or you can, whatever, if you feel comfortable, you can use it that. So this is the end result. It's an early gastric cancer, the patient doing well. And the most difficult area is duodenum. And this is a case. In fact, we present this case and this got an award also. And this is a duodenal tumor, a very extensive tumor. And this happened to be the endoscopy of a doctor. And he wanted to be endoscopically. But I tell you, this type of lesion can be easily handled by endoscopic mucosal resection instead of ESD. Because ESD is dangerous in the second part of duodenum because of many reasons, thin wall of the duodenum, as well as the presence of pancreatic juice and acid pancreatic juice in the duodenum, which is likely to produce perforation. Here, what we have done is we have resected it because this actually gives a complete resection. But this defect has to be, the mucosa has to be closed. So you can use different techniques. Here we used a loop, endoloop, and then we try to close it. But we can use anything. You can use overstitch. You can use clips. You can use OTC clips, anything you can use. And the biggest problem with diurnal ESD is, I told you that EMR is safer, but better neoplastic lens is ESD. But the problem is complications are much higher. Very, very careful on that. So we all know about POEM. I don't there's nothing new in telling about POEM. POEM has really revolutionized the management of achalasia cardia. Now I don't think that very rarely patients actually go for surgery. And whether it is the type 3, definitely POEM is superior. And type 2, even type 2 is POEM is more advantageous. And type 1, you can actually choose for surgery or endoscopy management. But I would rather say that endoscopy management is so simple and easy, so probably POEM may be superior. But if you ask me which is the type of achalasia which requires POEM, I would rather say it is type 3. And the biggest problem with POEM was people told that there is actually increased incidence of reflex disease, GERD. Truly speaking, in my practice, if the symptomatic GERD is very, very uncommon. It's not very high. I'm not telling you it's not there. So when you do POEM, if you are careful, you can actually reduce that. But however, because this was a big problem, people try to do a fundoplication during POEM also. So this is actually a video I borrowed from Dr. Amol Papaye. And after you do a complete myotomy, you go into you use another scope also, actually a thinner scope to look at the illumination, double scope illumination. The one scope will go into the peritoneum. You can see the peritoneum and you do the dissection there. Then you start coming back to your identify the stomach. You use a clip and endo loop and try to bring it. And you can also look at with the endoscopy, whether you are doing and bring back the loop, you bring back closer to the end of your myotomy and tighten it. You can actually see endoscopy, you can see a very good fundoplication is done. The biggest problem is this actually you're leaving clips and loops, everything inside the stomach in the peritoneum, whether the long effects are not. But some reports say that probably this may actually loosen up and create problems. So now people think that you do a POEM. If they develop symptomatic reflex, you can do a fundoplication later at any time. So this is may not stand for long, but once you actually refine the technique, refine the equipments, probably this can stand longer. Another thing is Senges diverticulum. Many times it's though very uncommon. Very rarely you get it in your practice. And earlier we were just doing septotomy there. And now we have an interesting technique like this. You do identify the area. This is identify the esophageal lumen and also the diverticulum. Inject on just above the level of the Senges, make an incision just like POEM. The only point is that when you reach there, you should be able to find out the septum. Here is actually the septum there. Once you identify the septum, you start cutting it. See, this is the septum. One side is the esophagus, other side is the diverticulum. You need to cut up to the lower end of the diverticulum. See, you use an IT knife here. So the tip is ceramic fitted, so the chances of producing injuries, deeper injuries, much less. So you cut to the maximum possible, then come back and close just like POEM procedure. Poetry is another area. This is not my video. We have done something similar to this. This is actually a person who has got a stricture, and you use a stricture if it is less than 2 centimeter. Then you can do an endoscopic approach, which we have done using an EUS, etc. And then we have punctured it, which we presented and got an award during the SGA session. And this is actually which I borrowed. And this is a stricture which has got a discontinuity of esophagus at least 2 to 3 centimeter away. So you can see the scope here. And you do approach from both area. And above from here, you actually do a mucosal incision. Go there, go up to the stricture area. Then actually take a tunnel through the fibrotic area, reach up to the other end of the esophagus. Then you dilate it and then put a metallic stent and come back. So this is the area we submucosal tunnel. Here is a blind area. You reached up to the other end, then you put a stent. This is Poet tray. And another technique which have been described by an Indian author, Dr. Amol Bapai, he's actually identified an adult person who has got constipation and found that he has aganglionosis with producing constipation. He found a long segment of muscular spasm, and then this is used as a submucosal tunnel. Sorry. Used as a submucosal tunnel, and just like you do in poem, you do the muscle cutting, and somehow it's not working. Anyway, it is something similar to that of any myotomy, but you have to be very careful in this one because identifying this is difficult sometimes, and it may be just above the anal region. So it is only in the infancy. I'm sorry, the computer is stuck a little bit. We're all right. So if I close the program, I don't know whether I. This is the submucosal tunnel excision. This is a very interesting case. There are two tumors at the ischias. Submucosal tunnel is actually the idea of that came in. Just because once you can go inside the submucosa, why can't we just remove tumors arising from the muscularis mucosa or from the muscularis propria? So the tumors actually suitable for STER, submucosal tunnel excision and resection, is actually that arising from the muscularis propria. Those are arising from the muscularis mucosa. Some days it may be very close to the mucosa, so you may not make a tunnel. In those cases, it's better to do that, an endoscopic submucosal dissection and take it out. Here, actually, this patient came with dysphagia, and both the tumors were removed. You can see that actually when you go into the tunnel, you can see the white colored tumor. It looks more like a leiomyoma, and then once the mucosa is intact, then even if you cut it from the muscle, it's not going to make a problem. And it is bringing out, it's difficult because you cannot make a huge opening there. So we are using a snare and then manipulate and then bring out. And the other one is also taken out and the patient dysphagia is gone. So we actually did in two different sessions because of the time constraints. And coming to the area where actually we know that bile duct and the pancreatic duct take a major role in our digestive system. And every time, since the past itself, people started exploring the pancreatic duct and bile duct, either by radiologically or by endoscopically. And we know that there are so many techniques of imaging the biliary system. But people tried to look at that. And surgeons were doing an intraoperative colposcope to take out CBD, doing CBD exploration, remove stones. And even fiber optic colposcopes were available when people in intraoperative removal of gallstones or assessment of lesions. So it is found that cholangioscopy actually it has transitioned into widespread practice. Initially, when it was an operative procedure at the time, very rarely people started using it. When it was a mother baby scope, in fact, in 1995, when I was in Sohendra's unit, at that time, it is our duty to hold the baby scope, and the professor will handle the mother. So even at that time, it is found that the vision is not so good, and it's actually fiber optic. It gets broken up very fast. So the management becomes quite difficult with that. But later, because of the advancement of the endoscopic systems and the optics as well as electronics, this became much better. Now we have got single-use, single-operator cholangioscopes and pancreascope, and it is mainly used for diagnostic, but I think now it is mostly used for tissue acquisition and therapeutics. Now one addition has come in, percutaneous cholangioscopy, which I'll come to later. When you come to about intraductal imaging, we have ERCP, we have EOS, we have intraductal ultrasound, confocal laser endoscopy, and all those things. But Cholangioscopy is something new, and you have got peroral, which I told you, and different types, 2 operators, single operator, and 2 operators, mother baby scope, single operator is ultra slim endoscope, and spyglass. And after introduction of this new generation single operator cholangioscopes, the acceptability of cholangioscopy became very rapid. This is actually nothing but just to show you a video and how it is being. This is the normal bile duct. You can see it well. We can see the cystic duct orifice, but you need to use fluid irrigation so that it can be seen well. And this is actually used in the help of fluoroscopy as well. And the most important thing is the tissue acquisition. You can get a spy bite, and you can actually increase. You can get very good tissue for tissue acquisition sometimes. Now it is actually you have got a bigger size needed biopsy for that is spy max, and you get good tissue sometimes. This is a young female who has come with a bile duct tumor very close to the just below the bifurcation, and you can see actually it goes into bifurcation. Very funny type of tumor looking like that, and you don't know how this being biopsy is being taken. You get good tissues on biopsy, and this is the tissue, which was actually granular cell tumor of the bile duct. It's very rare. And you can also use confocal laser endoscopy for this one. And this is another area where you can use a spy because you want to do a GB stenting or pass a guide wire through the structure. Here actually we wanted to put a transpapillary GB stenting, and it was not going easily. So we actually used that for getting it. And now the new thing has come, that is really spyglass discover. We know that many times, when you do a PTBD and the patient has got cholangiocarcinoma, we use the spyglass to go through the percutaneous route and get the tissue. And we are successful many times to get a diagnosis of cholangiocarcinoma through the percutaneous route as well. You dilate it, and many times this is required by the oncologist for planning the treatment. And now a shorter length, the biggest problem is a long length. The spyglass is long length, and now we have got a shorter length spy discover for actually. And also another area where is pancreatoscopy, just to show you on IPMN where we have used a spy, and you can see the front-like structures you've seen here. And this patient has got patient had almost a total pancreatitis because there are 3 areas she had. It's a spyglass discover. So this can be used during operation as well as be used during percutaneous route. Coming to another interesting area of bariatric endoscopy or metabolic endoscopy. Sorry, I will come back to later. And this is actually on endoscopic ultrasound. And endoscopic ultrasound really has revolutionized the management and approach of lesions which are adjacent to the bowel. And the most important thing is from a diagnostic tool, I don't think that people use it anymore for staging and all because we have got very good cross-sectional imaging. Now the most important thing of use is actually not a diagnosis, but it's actually a therapeutic work. But of course, I agree that in bile duct and in pancreas, diagnostic workup is also essential, as also into know about the lesions arising in the bowel wall, still be used as a diagnostic purpose. But mostly people use only linear use, and that is for therapeutic purpose. And the most important is the tissue acquisition. There are so many array of procedures coming out through endoscopic ultrasound. And this is actually the histology needs. There is a drastic change from US get FNA to that of US get FNB. That is why all these needles are there. We are not bothered about 22 gauge needle, 25 gauge needle, and 90 gauge needle, conventional to get a biopsy. Now we have got tissue acquisition needle. This is actually FNB. The idea of ROS, which actually makes a lot of logistical issues, and that has been changed now. Now you do a MOS, macroscopic on-site examination. You get a tissue, very good tissue, core tissue, and you get a lot of tissue. You can do histopathology, you can do spear, as well as you can do immunohistochemistry. You can do molecular studies, whatever you want, because the tissue is so good with all these type of needles. And all it is initially Procor came in, and then the Acquire, and then Nishison, and all these needles are excellent, and we will get very good tissues of that. So why it is important is that once you get an accurate diagnosis and more diagnostics are available possible, then it precludes the need for a rapid on-site examination. Coming to another important area of pancreatic fluid collection, I know that the approach of that has drastically changed. It is EOS gate drainage for almost all practical purposes, unless, except in those situations where it is away from the bowel wall. then you cannot do that. Then you have to go either surgery or a percutaneous one. And US has really made a lot of difference, and especially with the introduction of newer stents, it made the difference. You know that we all know about this plastic stents, which we used for double pigtail one or multiple for into the pancreatic fluid collections, especially for if you still we use it for very clear collections without any debris in that, or less than 10% debris, less than 30% debris, we actually use multiple plastic stent or even a nasocystic drain. If the debris is more than 30%, then you have to use some sort of a tissue or a lumen opposing stents like Nagy. It's not a true lumen opposing, or Spaxes. And the classical one is the Axios, which has got a tensile force and actually bring in. This is actually, we are creating an opening outside the stomach into the peritoneal cavity. Actually, it's not into the cavity because there is actually a granulation tissue has made and a cyst-like appearance. But if your cyst wall is not mature enough, you can actually, the granulation tissue will give way and you can actually go into the peritoneal cavity. But when you use systems like this, Axios and all, it's very rapid, and it is actually a lumen opposing capacity is there, and that efficiency helps it a lot. And you can actually go inside at any point of time. You want to go inside even with the other stents, some metallic stents, you can actually go inside the cyst cavity and take out the necrotic material if required. Now the concept is not to do that. Now the concept is just put a stent, wait and watch. If it clogs, drainage inadequate, you go inside and try to take out the clog, put a plastic nasocystic, drain it, and still it comes a problem. Then you go inside and take it out. Necrosectomy is done. So necrosectomy is less commonly used now, but you require that, but in less than 10 to 20%, I mean nearly 10 to 15% only require that. This is actually, we are putting a Nagy stent. This is the linear eoscope. You can see this needle. You don't require any fluoroscopy here. You can see this, the distal fare coming out. Already a tube was there for the patient. So you can see the purulent material coming out here, just below G junction. And this is for the bile duct drainage. The same stents, especially the Axios, can be used for many other others. And this is actually a bile duct drainage. And we have used a wide bile duct, a precarious position. We are not able to hold the position much. So we wanted to have a very quick procedure. So we are using an Axios here for the bile duct also. So you have got Axios ranging from the lumen opposing stents, especially Axios from 0.8 and up to, I think, 2.5 is there for GI and etc. So for bile duct, you use the thinner, smaller one, and you use 2 centimeter or 1.5 centimeter for the cyst, and the bigger one for the GJ. And this is actually, EOS has made your procedure much easier. When you get a difficulty to an ERCP, you can enter the bile duct either by a rendezvous technique or access and put a stent through the duodenum or through the stomach and do a hepatic gastrostomy or access either antegrade or retrograde that. Then another interesting area that has come into the field is that drainage of gallbladder. We know that acute cholecystitis, the patient is sick enough, and percutaneous drainage and or surgical laparoscopic drainage is the commonly one used. Now, if the patient can tolerate, we can actually use endoscopic drainage of the gallbladder. This is actually a case with the gallbladder stone. You can see that gallbladder stone, acute cholecystitis, sick patient. And you can, the bile duct also shows a small stone. So we did an ERCP. You can see the small stone is being taken out. So we thought we'll just go into the bile duct, we'll go into cystic duct and put the transpapillary stent. But it was not easily possible because the guidewire is not going because the stone is getting blocked there. So we finally found it difficult. So we decided to go in with the EOS guided gallbladder. You can see the thick walled gallbladder. See the very thick walled gallbladder here. Edematous. And an Axios stent is being placed there. You can see the flare there. It is pulled to the wall, so it gets opposite. You can see the dirty bile, the infected gallbladder drainage is coming out from there. And you can actually dilate it and go inside, and you can look at the stones, and you can, if you want, you can take it out and come. So we are just going into the upper GI scope. We can see we can inside the gallbladder wall, the mucosa is so bad, there are multiple stones, and that is the end of the procedure for that. Another interesting area which has come, and probably it will take up into a wider area, is the EOS gated liver biopsy. What you require is a 19 gauge needle and do sharp punctures, but minimal fanning. You need not do a fanning on that because you don't want to make any tear on the capsule. Rapid 4 strikes, 2 passes, and then express the whole thing into stylet without any, only with the stylet, I mean, into the formal bottle, only with the stylet, not push, because it will get scattered. So you identify an area with lesser vasculature, then use a 19 gauge needle, go inside. You can see that we almost, we are not doing any major fanning there. And you can see that this is pushed out with the stylet and long tissue is got. Another interesting area is EOS gastrojejunostomy, and we have got a special interest on that, and because we designed a tube for that, and Dr. Pragasakre is instrumental in that. And here is a case of gastric outlet obstruction for carcinoma pancreas, and we are not able to go inside, so we passed a guide wire there. You can see this is the scope which, and then over that we pass an indigenously made balloon. You have 2 balloons, and in between the 2 balloons, you fill with the methylene blue and identify the bowel. So this is the bowel which is closer to the stomach. So we use an Axios lumen opposing stent there, and we make sure it is bowel because you can see the valvulae coniventus, and also we can actually inject fluid and see. And this is actually the tube there with the balloons there. This is the lumen opposing stent being delivered and pulled towards the stomach wall. And once it is there, you release it. And since we fill it with methylene blue, you are make sure that you have punctured the bowel only, because we fill the bowel with methylene blue. That is a good technique, and you can dilate it, go inside and see the small bowel, and make sure that the lumen is adequate. You are using a CRE balloon, so you are sure you are inside the bowel. And fortunately, it is doing so well. And the opening is sufficient enough for people. We don't take out the stent, we just leave it alone, and most of the people are doing so well. And coming another important area is EOS gated vascular intervention. Esophageal varices, you may wonder why you require EOS, but people have found that the sclerotherapy or banding can become more efficient if you identify those perforators, especially in patients with recurrent bleeding. And if you are able to look at the perforate and inject and obliterate that, they will be very well. And gastric varices sometimes becomes a pain, and glue injection is the most efficient one. In at least in difficult cases, you can use EOS gated technique where glue and coil, or coil alone or glue alone, the combination is much superior. And also in non-variceal bleeding, this is what we use. Another interesting area is coming is what the hepatologist venturing into EOS used techniques for pressure management, etc. So this is just a short video, because I'm sure you'll also be doing it. This is actually large varices there. Make sure that it is varix and use a 19 gauge needle there. We go inside, we put a coil there. Measure always, make sure that the coil is, and then the rest of the area we actually use a combination of coil and glue, because coil is a little more expensive, and coil has got a wool-like appearance inside, so that the glue will glue into it, and then it becomes. Another important area, as I told you, is the portal vein. What are the potential applications in portal hypertension or with the portal vein? One is that you can do a PPG, EOS gated portal pressure gradient. People have even tried intrahepatic portal shunt only in animals now. EOS get FNA of portal vein thrombosis for staging SCC. You have found that you have got a SCC, a small SCC, but the portal vein is thrombosed. The patient would like to go for a transplant or want to like do a surgery. It's very difficult to get a tissue of the portal vein, but EOS can easily reach there. EOS can go inside, even to the hepatic vein, and then you can take a biopsy from that. And if that shows tumor, then you are out. You cannot do anything, and except for palliative procedures. If it is only a blood clot with no amount of tumor inside, then actually he can be taken out for a better procedure for that. And is that also you can find out, take out circulating tumor cells from the pancreatic biliary malignancies by sampling the portal vein blood sample and then send for that. Another is you can select out injecting chemotherapeutic agents. It's known as EPIC or even microbits, drug-eluting microbits into the portal venous system. Just like tear procedure, you can actually do something like what do you call chemotherapeutic effect for reduction of tumor. But here, instead of artery, we are using vein. Because the problem with the artery is many times when you use artery for embolization of these techniques, even with the angiographic technique, they develop bile duct stricture because the bile duct is supplied by the hepatic artery. You cannot select that too much. You cannot escape from that. And also in patients with the cholangiocarcinoma, where you want to do a selective portal vein embolization, we can actually use EUS. This is actually very good enough, and it comes very close to the portal bifurcation, and you can inject blue coil, whatever it is you require, and then you can do that. This is just a picture actually showing, this is not mine, it's actually taken from the textbook. It is actually, you can see liver, and it's a 25 gauge needle is used, and you get into the portal vein, and you can measure the portal pressure there. You can get in the hepatic vein, measure the portal hepatic vein there, and find out the hepatic gradient. This is actually a video I got it from the people who make it. You can see this is the hepatic vein. This is the mid-hepatic vein. How beautifully you can see it's a G junction. Look at the IVC, and then you actually trace out the veins. The right hepatic vein. You can see the needle now coming out, and you just go inside. So you know that make the pressure and all. And sorry, the Doppler study, make sure that it's the vein, and then finally you try to bring out. You can see the needle coming, 25 gauge needle coming into the hepatic vein. Yes. And you can see this is the pressure gradient which comes out at that proximal end of that. That will tell you what is the pressure. That is the 13 mmHg. That is the hepatic vein pressure. Then you take it out, come back to the portal vein. So usually we take we will take three values average, and then you take the average of that. Just like when we do a transigular portohemodynamics, and then come back to the portal vein, just close to the bifurcation inside the liver. Because you are not extra hepatic, you are actually going through the liver. Go into the portal vein and measure it. Then you get the gradient there. So no transigular liquid, no vascular access liquid, just do a EOS and try to do that. This is just coming into the market. I'm sure it will be soon available. So here we get the portal pressure gradient is only 1.3. So there are studies, there's a pilot study which actually found that this is quite useful and it is practical and possible without any complication. Another is actually for tumor analysis. This is just to show you that it is accessible, easily accessible, we can do that. Endoscopic ablative therapy, especially using the ERCP and USAID is possible for pancreatic tumors. Functioning endocrine tumors of pancreas like insulinoma, an elderly person cannot operate. You can inject absolute alcohol and ablate it. And pancreas cystic neoplasm, you can approach it as well as you can ablate it in non-operative patients. Coming to metabolic endoscopy, you have this is just to reduce their weight as well as for lifestyle disease like diabetes. There are different techniques which I cannot go in details of all this, but you should know about restrictive technologies, what are available. And the commonly one used is the first two. The intragastric balloons and endoscopy sleeve gastroplasty. There are so many other available. Basically, it is actually to reduce the size of the stomach, the function, as well as the volume, so that you have a restricted volume there. The technology actually reduces the size. This is just to show you the technique of
the endoscopic sleeve gastroplasty is a non-invasive
It's okay. I will put the sound very low.
endoscopic procedure designed to reduce gastric volume. This animation
and you can see that you go into, are you able to hear me?
Technique. A
Sir, probably you can
device such as the
mark
the
your
anterior and posterior walls
area
of
where
the
you want to
stomach
make
along
the
the greater curve.
puncture. The
This creates
bite.
a guideline for the
You
first
use a
outer
suturing
row
device.
of sutures. The first row of full thickness stitches is placed from distal to
3 bites are
proximal.
taken.
A running
At 2
triangular
different
suture
levels.
pattern alternates from anterior wall,
Then tie it.
greater curve, posterior wall, and is repeated for 5 to 6 bites.
You similarly do at
The
different
anchor
level.
is then released, and the stitching sequence, the triangular pattern, is repeated. A total
So
of
you see
5
that
to
it is
6
actually restricted.
triangular running
But if you want
stitches are
to, if
repeated
you think that
in
still it
this
is not
first row.
sufficient,
This
you
suture
can go in
pattern
again.
is designed to maximize the reduction in stomach volume and foreshorten
Again, if
the
you want, you can
repeated
actually
running
restrict it
stitches
further.
is placed following the lesser curve to create the sleeve.
Then are you able to hear me?
Yes.
Malabsorptive techniques where you use an endo barrier, absorption in the duodenum can be reduced. Or you do a resurfacing. Now we know that for obesity or for diabetes control, duodenal mucosa plays a very important role. And mucosal resurfacing is found to have some benefit on that. What you do is you go into duodenum, protect the ampulla, and then inject solution there into the submucosa, and the mucosa is burned using RFA technique or any thermal technique. Then delayed gastric emptying time you can use in persons. Sometimes people use the botulinum toxin actually produce a gastroparesis type of picture, and then or you can use a shuttle, a transpyloric shuttle. Actually, when the food tries to go into the duodenum, a ball-like mechanism which goes into the pyloric opening and process it, and only a small amount of it will go into the duodenum. And altering the gastric wall compliance also is possible by different techniques. And coming to the next area of EOS guided approach, that is non-varicose area, which is not explored much, but actually it is there. There you can actually do a lot of things on that. And even EOS can actually do a lot of things on that. But now we know that in spite of using clips, instead of using injection therapy, there are some patients do not respond to this type of thing. And now we have got a lot of other things which can be used. The commonly or simplest would be the hemospray, but it is not easily available here. Or newer spraying techniques, which actually gives you time to do a definitive procedure at a next point of time, earliest time. And injection actually EOS guided angiotherapy. We have got some experience on that. We look at the vessel, inject with 0.1 ml, 0.2 ml, 0.2 ml of glue, and you can actually obliterate, and then it becomes. And those patients who do not respond to repeated endotherapy, I think you should use an EOS, look for a vessel. And when there is a large clot in a visible ulcer, I think it's better that the EOS will sometimes get, and now sometimes give you an added advantage. Now actually a Doppler probe is being developed for this purpose. And people are trying to use cryotherapy, coagulation grasper, which we used for POEM and all, radiofrequency ablation, and mechanical. Most important thing is now people are trying to use over-the-scope clip system. With a large ulcer, but it's a huge vessel, is better to use a OTC clip. And endoscopy, suturing devices, etc., are coming into that field, which I'll come to later. New endoscopes. I'm not spending much time on this because EOS, you know that forward view now is available. We were using it for the last 6-7 years, but now the industry has come up. Why you use it? Basically, it is for glue injection. For EOS guided coil and glue injection, or for us looking at hilar lesions. And sometimes in hilar lesions in conventional use you don't see. Then this can be used. And certain difficult cystogastristomy and difficult EOS FNA where it's inaccessible easily, there you can go inside. And I have done in a case of difficult D3 cystogastristomy. A patient has got a bulge in the D3 and it is not easily, linear scope will not go easily. We use forward scooping and we put a stent over, metal stent over it and came out. Other thing is, which I already told, EDOF scopes, extended depth of vision scopes. Then spy discover I already discussed. And then single use endoscope is coming in a big way, especially in the Western world. There are people who have tried upper GI, people have tried colonoscopies or at least removal or tip removal, and even duodenoscope. At least 2 companies are there with the scope, and already Exalt is marketed in India already. And accessories, I have already told you about USFNB, the different types of needle, closure of perforation, stents, especially lamps have made a real disruptive changes in the field of endoscopic management of fluid collections, and then endoscopy resection. And we have needles with, you know that you have to inject, you have to cut. Now we have got the same needle where you can inject as well as you can cut. So that is good. And when you do an EOS gated procedure, the biggest problem is that when you rend away, you want to see the gateway go below, or you want to go the gateway want to go for colloidal. The biggest problem is actually manipulate the gateway. So a new needle has come inside. It's a steerable needle. Here actually you can see that the needle can be adjusted from outside the tip. So you can turn it up or down. And this is available now. And you can see here, you can actually adjust the needle and you can rotate it so the guide wire can go inside. Otherwise, when you conventionally pull the guide wire, adjust it, the guide wire will get the outer covering of the needle will get shade off. Then the procedure need to be abandoned. And here actually we can actually guide the guide wire because of that. So it's an advantage. Then you know that in clips in endoscopy, we can use it for bleeding, we can use it for perforation, but the new clips like Ovisco clips, over the scope clips, they're actually doing a lot of good possibilities, exploring new possibilities that when you got a perforation, you can secure the perforation well. If the perforation is big enough, then always use a Ovisco clip rather than using a conventional hemoclips. This can ensure it better. Or we use an endo loop to close that. And in bleeding also, when there is a large vessel, if you are not able to see it properly, the whole thing looks like a difficult one, then actually you can use a Ovisco clip because it actually goes inside and the whole thickness can be brought in. And when you want to do a full thickness resection, there also actually, suppose this is a tumor here, and it is a difficult area to do an ESD, then you can use Ovisco clip and you can even cut through that. Then sometimes, the biggest problem with when you are going to put a fully covered stumps, or a patient has got carcinoma esophagus, you do a stenting, they go for radiation chemotherapy, it will migrate away. So the patient will come back again with you. So can we do something like that, fixing the stent is possible. So these are the over the scope clip device systems. There are 3 different types are available. And this is for a perforation, the clip is being applied. You catch hold of that area. Once you are secured, sure that it is inside your area of interest or inside your cap, you can bring it. You pull it towards and you have a red out, that means it is done. Then you release the clip. Your assistant will release the clip. So it is done there. This is actually to show a case of stent. You put the stent to prevent migration. We have used an Ovisco clip, over the scope stent fixing clip. It's actually slightly different. And you can even release it after you can cut it and release it also when you want to take it out. This is especially useful when you have got a perforation which cannot be handled with Ovisco clip. You put a stent and then you fix it with that. Or when you, as I told you, for patient going for chemotherapy, radiotherapy, you can use this. Another interesting thing is that the overstitch, which has actually made a lot of difference for many things, sleeve gastroplasty, in perforation, even for ulcer, when you have to, just like surgeons are suturing the ulcer from outside, underrunning, they can do endoscopically.
Please mute, Jagdish, please mute.
Or you can even do that in you can actually do it for perforation as well as after POEM, you made a mucosal closure, or even after ESD, in duodenal ESD, if you want to do a mucosal closure. So many areas can be used. Here actually you use a suturing device. It looks a little difficult, but it's not that. You can just like do it, just like what you do in a suturing, you can close it. This is actually a cartoon. So the usage of strictures, usage of stents for benign strictures have made some difference recently. This is because many usually we use plastic stents, multiple plastics for biliary stricture or for pancreatic strictures. So this is nearly getting replaced with the self-experimental stents. You cannot use a uncovered one, you have to use a fully covered. The biggest problem with fully covered is migration. So this can be avoided by the stents now available with the flaps which cannot migrate proximally or distally, or you can use some other techniques like using clips, etc. to retain this. So this is a new technology, and probably there are good fully covered stents are available now, and benign strictures can be managed, or even in complications like post-ERCP perforation, put a fully covered metal stent, everything is over. Or patient has got torrential bleeding from the bile duct, and especially for portal biliopathy, or when you do a sphincterotomy, there is a huge amount of blood coming up, and you try to close it and doesn't work out. Then if it is manageable, you can put a fully covered metal stent and see how it is coming out. But if it is from the portal biliopathy, this is very efficient. We have found that it is quite good. And even in pancreatic duct stricture, this is when there is a dominant stricture, you can use a metallic stent, and it has to be removed after some time. And biodegradable stent we have been listening for quite some time, but now it is coming back again with new vigor. And coming to the last one, that is the artificial intelligence endoscopy. You know that when we see a neoplastic lesion, looking at the mucosa, if you are able to say that this is malignant or non-malignant, this is a suspicious one, or this can be left alone. This needs to be sent for histology or not. That makes a lot of difference. Or your endoscopy, the pickup rate, even if your younger colleague or a person you are doing in the periphery, if he also cannot miss any lesion, the pickup rate can be increased. Then artificial intelligence of ease of use in clinical practice. So it is a computer-aided diagnosis, especially in colonoscopy in the Western country, because their colonic polyps are a very important area of interest for them. And colonoscopy, as we know, that is an inherently imperfect procedure. It depends upon the person who does, it depends upon the person's preparation, it depends upon the colon nature of the patient, because it's a large colon and a difficult colon, previous operations, etc., makes it difficult. And also the way you withdraw the scope, how fast you withdraw. So many variables actually is there. But if you can actually, a computer can help you out to tell you, hey, there is something. It actually shows a color there and say that there is actually a polyp there. Then you actually carefully look at that. So computer-aided detection of polyps or lesions actually improve the quality of the procedure. So how it is being done? It is, what are things done is automated polyp detection, automated polyp characterization. In what we have, I shown you in endocytoscopy. It can tell you it's an invasive cancer, or it can say it's an adenoma. It can say what it is. And then, in other words, it can do an automated polyp detection and characterization. So there is a machine which is coming by Olympus company which can do a detection, characterization, confirmation, and this will ultimately end up in treatment. So actually, they use a neural network to find out the lakhs and lakhs of pictures are fed into this, and then actually it can detect there is a lesion. Here you can see that just a computer says that there is a suspicious area there. It just marks there. By looking at that, probably you can say that I need to look at that area. So the moment a polyp comes, the computer makes an area there. You can actually do different types of picture also. You can actually make it bigger, or you can normal mode, or you can get a target mode as well. This is known as Endo 8, and this is being marketed by Olympus company. There are so many other companies coming in with that. Sorry, I don't know what's happening to my computer. I think it is time to stop. That is the reason.
Seems to be the last slide, no?
It is nothing much. So,
Yeah.
my dear friends, my younger colleagues, my teachers, my friends, I have tried to narrate you or made a very rapid pass of just like a rapid wind just going through a lot of new areas of endoscopy. Endoscopy is a so fascinating world. I actually want to show you another future of endoscopy slide, but I thought, this will be too much for you. And the third space is an area which really is going to be revolutionized. And I want to show you what is the future potential of third space. It is something like that. You can give targeted therapy. You use third space to go into for implantation. People are also thinking about doing gastric pacemaker implanted into the stomach through a third space surgery. And people are trying to look at and take biopsy from the muscular muscles as well as from the nerves by looking at the going into submucous space. And even capsules are being devised to identify abnormal area. Go there, dissolve, bury, and go inside the submucosa and deliver the treatment and come back. So either chemotherapy or locally acting steroids or locally acting other agents or future biological therapy, whatever it is, we don't know. So this is a very wide area, and endoscopy is very fascinating. So I cannot tell that everybody should take up endoscopy, but I only want to say that endoscopy is a very vast field. If you are really interested in endoscopy, you should. This is to my younger colleagues who are doing DM and DLB. You should take up this in a big way and go after your DM course or DMA course. Go for selective training in endoscopy, and then it is a very fascinating field. Thank you so much.
Thank you, sir, for that wonderful lecture. I think it was quite exhaustive. Take some water, please.
Krishnas, are you there?
Yes, sir. Yeah. You cannot hear me?
Yeah. You are visible, audible.
Okay, thank you. I think we have a lot of seniors here. Dr. Naren, sir, would you like to comment? And Dr. Prakash Sakaria is also there. Naren, sir?
We acknowledge the presence of Narendran, sir. Sir has come online. Then Professor Vinay Kumar, Robert, Dr. Ismail, Roy Mukada, Dr. Banu, Rajesh.
So
Okay.
Naren, sir is there.
As usual, it was a very wonderful lecture, and I really gained quite a lot from it, and it has gone off from our hands. I think it has become so much sophisticated, and then we can do such a lot of things. And I sincerely believe that the nascent gastroenterologists would have been excited sharing this. And that's what these lectures should be. I think they get more attached to the specialty with the things that they are being done. And thank you, Dr. Matthew, for a wonderful lecture. Thank you very much.
Dr. Prakash, Dr. Matthew Phillips, right hand. Can you say something? Would you like to say something?
He is not my right hand, he is my both hands.
Okay. Prakash?
Yeah, Dr. Matthew has taken you all through different newer developments in GI endoscopy. I think there is nothing much left now. There is a lot of scope of improvement. There are so many things in the horizon. I'm sure this would be of great benefit to all our younger colleagues who has listened to the newer developments. Thank you, Krishnas.
Dr. Ismail, Dr. Bhanu.
Varghese Thomas and Krishnas, I want to make a correction. Initially, I told that some of the procedure, Varghese Thomas told that it started by some other. Actually, first poem was done by Dr. Roy Mukada, and second onwards we started doing. So we had to see that. I was thinking that mostly it is attended by PG students. It's attended by everybody. Right?
Yeah,
faculty will also attend because it's a learning exchange program.
We should get a lot of inputs from others also.
Yeah. Is Dr. Roy there? I didn't see his name.